clinical syndrome characterized by rapidly developing clinical signs and symptoms which are related to focal or global cerebral dysfunction. The signs and symptoms should be more than or equal to 24 hours, or it should cause death to call it as stroke. And there should be no any other apparent cause other than vascular cause causing stroke. This is the WHO definition for stroke. Under stroke, we have two broad types, that is ischemic type and hemorrhagic stroke. In ischemic stroke, we again have thrombotic stroke, embolic stroke, and lacunar stroke. The thrombotic stroke is the most common one, where we see stroke due to arterial occlusion, large vessel occlusion, which is secondary to atherosclerotic plaque rupturing or ulcerating, causing thrombosis inside it. So this is thrombotic stroke, most common one. Then we have embolic stroke, which may be due to artery embolism or due to cardioembolism, which is secondary to atrial fibrillation, mitral stenosis, infective endocarditis, and all. The lacunar stroke is the disease affecting small vessels between 30 to 300 microgram due to lipohyalinosis, where hypertension is the risk factor for developing lacunar stroke. Then we have hemorrhagic stroke. Hemorrhagic stroke is intracranial hemorrhage. Under hemorrhagic stroke, intracerebral hemorrhage is there, cerebellar hemorrhage is there, subarachnoid hemorrhage is there, subdural and extradural hemorrhage is there. So hemorrhagic stroke is clinical symptoms caused due to hemorrhage into the brain parenchyma or around the brain. This is about hemorrhagic stroke. Now we are seeing transient ischemic attack. What is transient ischemic attack? It is a brief episode of neurological dysfunction caused due to focal ischemia of brain or retina. These signs and symptoms last for less than 1 hour without any evidence for infarction on imaging. This is about transient ischemic attack definition. Transient ischemic attack is a warning sign for impending ischemic stroke. The highest risk for patient to develop ischemic stroke is first 48 hours following transient ischemic attack. We have three types of transient ischemic attack, that is embolic transient ischemic attack, large vessel transient ischemic attack, which is nothing but due to thrombosis of the large vessel, and we have lacunar transient ischemic attack. The embolic transient ischemic attack is characterized by recurrent signs and symptoms which are only lasting for few minutes. And in large vessel transient ischemic minutes to hours, in large vessel transient ischemic attack, we have long-lasting, less frequent signs and symptoms. And also we have lacunar transient ischemic attack. The idiopathophysiology of transient ischemic attack is, see, the transient ischemic attack is caused due to embolism, thrombosis, and lacunar transient ischemic attack. So most of the risk factors are similar or same as ischemic stroke. We have modifiable, non-modifiable. We know for developing thrombotic stroke, we need atherosclerotic plaque. For that, all the risk factors of developing atherosclerotic plaques comes here. We have modifiable risk factors like dyslipidemia, diabetes mellitus, alcohol, and smoking, and then reduced exercise, obesity, and hypertension as modifiable risk factors. This predisposes the patient to develop atherosclerosis and thrombotic stroke, transient ischemic attack, and then thrombotic stroke. And then we have cardiac risk factors like for embolism, which are atrial fibrillation, acute myocardial infarction, and infective endocarditis. These subset of patients develop embolic type of transient ischemic attack. The non-modifiable risk factors for developing transient ischemic attack are prior stroke, old age, family history of stroke, and male gender. Then let's see the clinical manifestation of transient ischemic attack. We have neurological deficit similar to that of stroke, that is hemiparesis and aphasia. Because it is nothing but transient ischemic attack is also caused due to the vascular insufficiency, which is similar to that of stroke. We can have hemorrhagic fugax, which is transient loss of vision due to retinal ischemia, and we have hemisensory loss and vertigo in transient ischemic attack. Coming to management of transient ischemic attack, we have investigation CT or MRI to rule out other intracranial pathology. We have the Doppler for carotid artery and vertebral artery to look out for stenosis of these vessels, and we should perform ECG and echo to look for cardiac causes for embolism. We can perform blood investigations like CBC and lipid profile. The treatment for transient ischemic attack is the reduction is done to reduce the risk for developing stroke. Those are medical treatment. We have antiplatelet agents like aspirin given as 300 mg loading dose followed by 75 mg OD dosing. Or else alternatively we can give first 4 weeks by platelet therapy, double platelet therapy, where we give aspirin and clopidogrel followed by aspirin therapy, meaning first 4 weeks we give aspirin and clopidogrel, followed by it we only give aspirin. Then we can give statins, that is rosuvastatin and atorvastatin, and we can give anticoagulants if the patient has embolic transient ischemic attack to prevent the future attacks, that is warfarin and heparin. And then the interventions, we have percutaneous transluminal angioplasty, that is stenting, and internal carotid endarterectomy if the stenosis is more than 70%. This is about transient ischemic attack. To summarize, transient ischemic attack is a brief episode of neurological dysfunction caused by focal ischemia of brain and retina. Types, we have embolic TIA and large vessel TIA and black snarl TIA. Idiopathophysiciology risk factors, we have modifiable risk factors like cardiac embolism, which can be due to atrial fibrillation, acute MI and infective endocarditis, hypertension, and alcohol intake, smoking, diabetes mellitus, dyslipidemia, reduced exercise, and obesity as modifiable risk factors. Non-modifiable risk factors, we have prior stroke, old age, family history, and male gender. Clinical manifestations, we have similar to stroke, that's neurological deficit, hemiparesis, aphasia, hemisensory loss, and amaurosis, transient loss of vision due to retinal ischemia and vertigo. Management, we perform investigations, CT and MRI to rule out intracranial bleed, and then we perform Doppler of carotid and vertebral artery to look out for artery stenosis, ECG and echo to see for any cardiac pathology, blood investigation, CBC, and lipid profile. Treatment, we have antiplatelet agents, aspirin and clopidogrel. Statins, we have rosuvastatin, atorvastatin, anticoagulants like warfarin and heparin given in embolic TIA. The interventions, we have internal carotid artery endarterectomy and percutaneous transfemoral angioplasty. Next, we'll proceed on to discuss intracerebral hemorrhage, that is bleeding within the brain parenchyma. Intracerebral hemorrhage is bleeding within the brain parenchyma. It's the type of intracranial hemorrhage or the hemorrhagic stroke. Along with intracerebral hemorrhage, other causes of hemorrhagic, other subtypes of hemorrhagic stroke are subarachnoidal hemorrhage, subdural, and extradural hemorrhage. So we are discussing intracerebral hemorrhage. Coming to idiopathophysiciology of this condition, intracerebral hemorrhage, we have head injury and aneurysmal rupture, and some diseases like hypertension, brain tumor, cavernous hemangioma, polyarteritis nodosa, SLE, systemic lupus erythematosus. These causes vasculitis and hemorrhage. Brain tumor and cavernous hemangioma, they spontaneously bleed due to the tumor. And then we have coagulopathy as a risk factor, and anticoagulants intake of anticoagulant drugs is the risk factor for developing intracerebral hemorrhage. It will have mass effect on the surrounding structure, so it will cause the symptom. And also secondary to mass effect, we will have increase in intracranial pressure only because the volume of intracranial volume of the inside the cranium is limited, so there will be increased intracranial pressure, and also there will be cerebral edema, which cause these symptoms, symptoms of intracerebral hemorrhage. Under clinical manifestations, we have headache and impaired consciousness due to increased intracranial pressures. We have focal neurological deficits based on the location. We'll discuss it shortly. And then the patient can have seizures, and some may develop coma if they have pontine hemorrhage or severe other kinds of intracerebral hemorrhage. The patient may have signs of meningeal irritation if there is extension of hemorrhage into subarachnoidal phase causing meningeal irritation, where the patient will have neck stiffness. Focal neurological deficit or neurological impairment that we see in these patients with intracerebral hemorrhage are in putaminal breach. Putamen is the part of basal ganglia. In putaminal bleed, we'll have hemiplegia, hemisensory loss. Hemiplegia because you can see here, putamen and hypothalamus are in proximity with internal capsule. So the putaminal bleed can have mass effect on posterior limb of internal capsule, causing hemiplegia, and also it can have mass effect on other structures like thalamus and all, causing hemisensory loss, homonymous hemianopia due to involvement, mass effect on optic radiation, and as gaze palsy and coma. These patients can develop gaze palsy and coma due to amyloid bleeding. Then we have cerebellar bleed. In cerebellar bleed, there is bleeding inside the cerebellum, where the patient will have imbalance due to disturbance in function of spinocerebral pathway, vestibulocerebellar pathway, and all. And then the patient can have vomiting, headache, gas palsy, and the patient can have coma, can develop coma due to brainstem compression secondary to cerebellar hemorrhage. So the patient have thalamic hemorrhages due to mass effect on posterior limb of internal capsule. We can have hemiplegia, hemisensory loss due to impaired functioning of ventro-posterior uh, ventro-posterior nucleus and ventro posterior sorry, due to hemisensory loss we can have due to impaired functioning of ventro-posterolateral and ventro-posteromedial nucleus of thalamus. And then we can have transient homonymous hemianopia due to the dysfunction of lateral genicular body which is the part of thalamic thalamus. Under, if the patient has lobular hemorrhage, that is involving the frontal lobe, parietal lobe, and occipital lobe, the patient is depending on the site of hemorrhage can have hemiparesis, hemiplegia, and then can have contralateral homonymous hemianopia if there is occipital bleed. Then if the patient has pontine hemorrhage, meaning the involving the pons, if the patient have bleeding inside the pons, he can develop deep coma because of the impaired functioning of reticular activating system, which is the part of pons. So these are all the clinical manifestations that we see in intracerebral hemorrhage. Coming to investigations of intracerebral hemorrhage, we have plain CT is the investigation of site, investigation of choice. It helps us to locate the site of bleed, and also to look for the size of bleed, and also we can identify the herniation if it is there, secondary to increased intracranial pressure. So the lesion, the hemorrhage will be hyperdense in the acute setting. Following weeks of hemorrhage, it will be isodense, followed by hypodense ecotexture. Then the MRI, we can do MRI to detect bleeding in case of chronic intracerebral hemorrhage. MRI is superior than CT in detecting chronic intracerebral hemorrhage. And then we can perform blood investigation like RFT and lipid profile and all. Under treatment, we admit the patient in ICU and strictly monitor the neurological and hemodynamic functions of the patients. And then to reduce the bleeding, we give hemostatic therapy, where recombinant factor 7A has been found to reduce the bleeding as well as progression of hematoma. Then if the bleeding is due to BP, hypertensive hemorrhage, then we can give IV sodium nitroprusside so as to control systolic blood pressure between 140 to 160 mm of Hg. Then if the patient has bleed more than 3 centimeter, we should surgically evacuate the hemorrhage part, the hematoma. The increased intracranial pressure of the patient can be managed by mannitol and furosemide 20 mg 6 hourly. To prevent seizures, we'll give phenytoin 15 mg per kg IV infusion as a loading dose, given for 30 minutes, followed by 100 mg of phenytoin given every 8 hourly. And then if the patient was previously taking any anticoagulants and antiplatelets following the intracerebral hemorrhage, we should stop it for 1 to 2 weeks. This about intracerebral hemorrhage. To summarize, intracerebral hemorrhage is bleeding occurring within the brain parenchyma. Pathophysiology, we have head injury, aneurysmal rupture, brain tumor, hypertension, polyarteritis nodosa, SLE, coagulopathy. The symptoms seen in intracerebral bleed is due to mass effect, edema, and increased intracranial pressure. The clinical manifestations are headache, impaired consciousness due to raised intracranial pressure, focal neurological deficits, seizures, coma, meningeal irritation if the patient has involvement of subarachnoidal space, that is hemorrhage involving subarachnoidal space. Here the patient will have neck stiffness. Neurological symptoms in putaminal hemorrhage are hemiplegia, hemisensory loss, homonymous hemianopia, gaze palsy, and coma. In cerebellar hemorrhage, the patient will have imbalance, vomiting, headache, and gaze palsy, and they can have coma if there is brainstem compression. The thalamic hemorrhage, the patient will have hemisensory loss, hemiparesis, transient, homonymous hemianopia, and then in lobar hemorrhage, the patient will have hemiparesis, hemiplegia, hemisensory loss, contralateral homonymous hemianopia. Pontine hemorrhage, the patient will be in deep coma due to impaired functioning of reticular activating system. The investigation, we have plain CT to locate the bleed and the size, to see the size of the hematoma, and then we can detect herniation. MRI is preferred in chronic intracerebral bleed. Blood investigation like RIT and lipid profile can be done. Under treatment, we have ICU management where we monitor neurological and hemodynamic functions of the patient closely. Then the bleeding will reduce by giving hemostatic therapy, that is recombinant 7A factor. And then in case of hypertensive hemorrhage, we'll control the BP between systolic BP between 140 to 160 mm of G by giving IV sodium nitroprusside. And then if the hematoma is more than 3 centimeter, we should surgically evacuate it. Increased ICP is managed by mannitol furosemide 20 mg 6th hourly. Prevention of seizures by giving phenytoin 15 mg per kg loading dose followed by 100 mg 8th hourly. And then if the patient was previously taking anticoagulants and antiplatelets, we'll stop it for 1 to 2 weeks. Thank you for listening.